Good morning, and thanks very much, Mark, for the introduction and the overarching review that you just gave. I'll launch straight in. A very brief bit of history. I've been involved with the ACE kind of process for some, 15, 18 years or so. I'm a retired professor of general practice at the University of Birmingham, and I've been using ACEs and similar kind of approaches to education for a long time. So what I'm going to do is I'm going to forget history now. I'm just going to go straight in, talk about what ACEs are, why we instituted them, and what sparked my interest. My time in academia has been very focused on education, much more than on laboratory or other kinds of research. Initially, we used ACEs in medicine only, and then in physician associates as well. So there's a extensive history, probably, well, at least 15 years, if not longer. So I'm just going to step back from ACEs as such and say something about simulation and why we need simulation and why I think we need more simulation and why I think we need high fidelity simulation, by which I mean real human beings, not computers or robots. But obviously there's an ethical issue about performing intimate or any kind of examination on patients. We published something about this in the Journal of Medical Ethics a few years ago. You can have a look at it if you wish. But the key thing is that the things we used to do as students when I was a student, which is quite a long time ago, we knew they were unethical then, and they're definitely even more unethical if you can have more or less unethical now. And we used to do things without patients' consent. We were introduced as, with these young doctors, is it okay if these young doctors examine you? The obvious answer is always yes, because the patient wasn't really given an opportunity to say no. So you should never do this kind of stuff, particularly in some examinations. My first female pelvic examination, I can still remember vividly. The patient was embarrassed. I was incompetent. I don't think I hurt her, but certainly I didn't know what I was doing, and it was ridiculous to learn in that way. That's one of the reasons we need to think about simulation. There's also the point that people need repeated practice and repeated and focused and relevant feedback. You don't really get that from a patient. You examine a patient, and often patients do know whether you're doing a good job or not, but we don't really give them a voice. And so we need to give a patient or a patient substitute, if you like, a voice, which I'll come on to a little bit more later on. There's also the issue that students have different levels of, this is obvious. I mean, my wife calls me the professor of the bleeding obvious, because it is kind of obvious once you say it out loud, that you need somebody who can work at the level that the student is at. We can't expect a real patient to do that. They've got their own problems, their own things to focus on. And ACEs can do that because we have trained them to be able to do so. They're also able to demonstrate certain kinds of pathology or abnormalities, which are really difficult to obtain for students to learn, and certainly for students to be assessed upon. So I'll give you an example. Patient comes off his bike, or her bike for that matter, injures their chest, maybe a couple of fractured ribs. Two things you'll find when examine a patient like that. One, they're in a lot of pain. Two, they're tender at the rib, but also if you flex the rib. And three, they have asymmetric breathing. And we have taught some of the ACEs, not all of them are able to do this, to do asymmetric breathing. So we can do an extremely convincing simulation with a real person that the student has to interact with just like a real patient they would, but they're not hurting somebody, they're not putting a patient through all that kind of discomfort. Just going to add a couple of other odd things before I, all preamble, but I want you to maybe think about, maybe afterwards, if you like, two of the principles that I've brought into the way we do this. It was traditional in medicine, I think it still is really, to learn about normal, to spend a couple of years learning about normal and then start to learn about abnormal. But particularly in physical science, I put it to you, and I can only assert this, that it's much easier to learn something that's abnormal when you have something normal to compare it with, and obviously vice versa. And the ACE is able to do this, is able to switch from, take my example a moment ago, asymmetric breathing to symmetrical breathing and back again, so the student can see the difference. And we as human beings are good at spotting differences. We're not good at spotting absolute values. And on a similar, but not quite the same theme, I worry quite a lot about, I don't lie awake at night, but I am concerned that if we learn something incorrectly, then it becomes difficult to unlearn it. And if I give you an example, if you're extremely good at music, this won't apply to you, but if you're like me and you have to learn a tune parrot fashion, If I teach you a tune, I'm not going to do it now, don't worry, and I put in an incorrect note because I don't know the tune correctly, and you learn it from me parrot fashion, and then somebody comes and says, no, 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 that's a C sharp, not a C. This is how it should sound. Most of us would find that very difficult. We find it difficult to unlearn. And so I think it's really important when students are learning physical examination skills that they compare normal with abnormal there and then. They get immediate feedback, and they are taught what the signs actually are correctly, rather than on these, to be blunt, awful mannequins, etc., which mostly I think are misleading. Now, just briefly, an aside, there's lots of pressure on the clinical encounter nowadays. The idea that you just wander around the wards fairly randomly, like I did as a student, is all gone. We've got austerity, we've got COVID, we've got huge increases in numbers, and most of these things apply all around the world. So pressure on clinical learning environments and the clinicians who might teach us has become more and more severe over recent years, and it's becoming increasingly difficult for students to acquire their skills, whether in medicine, physician associates, pharmacy. I'm sure it's true of other clinical professions as well. So we put all this together and say, what is an ACE? An ACE is somebody who's been trained to use their body and their psyche in educating clinicians by responding appropriately when asked to do so by a student. You know, would you please lie on your side, or whatever it may be. But they also know, and this is, I think, the special things about PAs, they know, I'm going to call them errors, I don't have a better word, the errors that patients make. So the experienced patient, when you want to take their blood pressure, knows exactly what you want to do. The inexperienced patient doesn't. And if the patient doesn't rest their arm properly, if their shirt is too tight, causing a tourniquet effect, both of those things will affect the blood pressure reading. The beginner has to know that. And so an ACE can teach the student how to do it correctly. What happens if you do it incorrectly? And you can see the blood pressure go up and down. If you try it, lift your arm up and down, flex your muscles, you'll see the blood pressure go up and down. So an ACE can do that back and forth until the student gets the reason for doing it correctly and demonstrates that they can do it correctly. So this is an immediate feedback, and students love feedback. They're always asking for more feedback, but this is immediate. It's relevant to the individual student's strengths and weaknesses, and they can improve straight away until they achieve whatever competence we're expecting them to achieve at that time. Obviously, it may not be competence as such. So as well as knowing the errors that patients, and I'm sorry about the word errors, there must be a better word, that patients make, they also are taught and use the errors that students make. So students, especially as beginners, we don't know what we're doing. The left hand doesn't know what the right hand's doing. Half the time we're poking about in bits of the body, we have no concept of what we're up to, certainly as learners. And I'll give you an example. Let's say you want to examine the patient's retina. So you want to examine the back of the eye, and what you need to do is give them something to look at. You need to keep your head out of the way while you're looking at their retina, and you need to move, give them appropriate instructions and so on. But if you don't give them appropriate instructions, don't forget, this is often an examination that's done on somebody who's got a head injury or is in some way cognitively impaired. Maybe they're drugged or drunk. So instructions have to be really clear. So we have taught, firstly, we've taught the ACEs how it should be done. Secondly, we taught the ACEs the errors students make, for example, getting their head in the way. And thirdly, we've taught the ACEs something which I haven't touched on yet, but will now, which is they know better than any teacher whether the student has performed the examination correctly. So for this example, we've all been to the optician, I'm sure, and they ask you at one point to look at the light. And the reason is they're looking at the macula, which I'm not sure of the background of everybody watching, but it's the bit of the eye that we really use for color vision and for reading and so on. That's why our eyes move when we're looking at a page. And when you have that experience as a patient, you get that sort of rather almost uncomfortable light in your eye. Therefore, the ACE, having been taught that's what happens when somebody looks at your macula, is able to tell the student whether they've got it right or not. Whereas when I'm watching, I can't tell. And similarly, we teach the ACEs things like, for those who are slim and relaxed enough, I can teach them what it feels like to have their liver edge palpated and what the timing is to get that correct, which is quite difficult when you're a beginner student. And the ACE knows what it's like, knows how to do it, knows the errors patients make, the errors students make, and knows whether the student has actually done it or not, which I, as an observer, don't really know. And certainly as a student, we used to blag that quite a lot because it was too embarrassing to say we didn't know what we were doing. So I'm almost at the end now. One last example of error students make, which I think is quite useful, is over complex instructions. And it's much better for the ACE will, if given over complex instructions or instructions that don't work, will do the thing wrong, and then we'll teach the student how to do it right. So in conclusion, I think I would say that what ACEs bring is they can role play, they can demonstrate abnormalities, including in assessments, of course, which is extremely useful. They can understand what errors students make, what errors patients make, teach them back to the student so they get it right. And what's the most important thing I want you to remember from what I've said, and I believe I'm getting towards the end of my 12 minutes or so, take the clinician out of the room. You do not want a clinician there. If you have a clinician there, you'll inevitably veer into discussions about what, for example, being able to palpate a kidney, what does that mean? Does it matter? Is it, pathological? Students will go down those routes, whereas the ACE can keep the learning event focused on the student's individual bespoke needs and work with them to achieve, as I said, whatever level of competence, ability, whatever it may be, that you're trying to achieve at that time. And I've touched on testing slightly. Of course, we can also use them. Anybody ever tested the ability of a student to examine an acute abdomen, let's say an appendicitis, in an exam? No, you haven't, because we just couldn't morally do it. You can use an ACE to simulate it, but that's not the most exciting part of it. It's the things that I've discussed in terms of education and feedback. Thank you very much. Happy to take questions at any time through the next.